Appalachian Wellness for a new tomorrow and a new you. I'm Raymond Oenbrink, the owner, CEO of Appalachian Wellness here in Asheville. You can follow us on social media if you like. We're going to talk about the complement system, specifically C3A and C4A, and how they're affected in CIRS. This is part of the immune system that we don't really study very much as a general rule, but it's a key component for understanding what's going on in this disease process. C3A tends to increase in the presence of foreign membranes. Borrelia burgdorferi is the causative agent of Lyme disease and causes a great increase of C3A, which can be used as a marker for the inciting event of a patient's development of CIRS. It's an extracellular pathogen that has the ability to hide intracellularly. It has a very slow doubling time, thus necessitating prolonged treatment with antibiotics. It can be hard sometimes to know when to stop the antibiotics in a patient who is obviously still sick and doesn't appear to be fully recovered from their tick-borne illness. The lack of recognition of this transition from acute infection to chronic inflammation due to a malfunctioning immune system in HLA genetically susceptible patients is an easily understood source of confusion. There are some references that will lead more information on this topic. C4A, on the other hand, is a marker for biotoxins in general, which is much less specific than the C3A bacterial membrane link. C4A levels can even rise in the presence of volatile organic compounds, VOCs, which are present in water-damaged buildings. Erythropoietin can lower C4A and TGF-beta1. It works well in CIRS mycotoxic patients, but it is risky to use. This use will be off-label and should involve documentation of informed consent in the chart. Baseline labs for this would include a TGF-beta1 C4A D-dimer because it can cause blood clots like blood clots in the legs and the lungs, which can be lethal, and a blood count. If during treatment the hemoglobin gets to be over 16.5, it's gone too high. The FDA does not want that hemoglobin above 10 grams. It's also a good idea to record the lot number of the erythropoietin product that's being used. Erythropoietin dosed at 8,000 units twice per week for 5 doses or until the hemoglobin is above 10. Beware of the thrombosis complications. Have a very high suspicion for the kind of episode that could be suggestive of a deep vein thrombosis in the leg or a pulmonary embolism in the lung, which can be lethal.